Everyone. Thanks for joining us for this really important and timely webinar on harm reduction. My name is Patrick Chu. I'm the Policy Lead Initiative here at the Association of Registered Nurses of BC. For those who aren't familiar with us, we are the professional association representing registered nurses and nurse practitioners across the country. Just to note that we will be recording this webinar, having it on our website. So if you have colleagues that didn't make onto our list, or if you want to watch it at a later date, please come back to our website to do so. I'd like to introduce our guest presenter, Danielle Cousineau. Danielle has worked as a nurse at Insight for the last 4 years, first as a clinic nurse, and for the last year and a half as the clinical coordinator for Insight, supervised injection site and on-site detox. Recently, Danielle moved into the interim position of clinical practice lead for primary care BCH Vancouver community, and she has an extremely good knowledge base on harm reduction in nursing practice. So this presentation will be about 40 minutes. We'll leave 20 minutes for questions at the end. And because we do have quite a bit of participants, if you do have a question, please click onto the raise your hand icon that's located on the GoToWebinar navigation bar that's on the right-hand side. And if you want to type in a question, just click on the arrow to expand, and your name will be put on the queue. So I'll let Danielle take over.
Hi, everyone. Thank you, Patrick and ARNBC, for having me come in to give this talk today. I'm very passionate about harm reduction, and I could talk to you for days about it, so I'll try and keep myself brief, and I'm open to questions at the end. So just to start with our goals and objectives for today, as I'm trying to advance my slides. Sorry, 1 second, technical difficulty. Get this fixed. There we go. Sorry about that, everybody. So our goal today is to increase nurses' knowledge and understanding of harm reduction approaches within the context of substance use. Our objectives for today are to clearly articulate the role of harm reduction within the context of substance use, clearly articulate the nurse's role in harm reduction. Hopefully you'll be able to list at least 2 harm reduction practices related to substance use and 2 harm reduction myths that you could then challenge with evidence-informed research, and identifying key principles when working under a harm reduction model as nurses. So to start, what is harm reduction? So harm reduction is an umbrella term that's used to describe programs, policies, and procedures that aim to reduce the negative consequences associated with behaviors that are typically considered high risk. 2 common areas that harm reduction is applied are substance use, which we'll be focusing on today, and sexual health. So an example in sexual health would be condom use, and education around condom use would be a harm reduction measure. So really what it is it's focusing on increasing people's safety and reducing the harms of inherently risky behavior. And it's part of a continuum of services. So it basically focuses on the individual and where they're at, and that abstinence maybe isn't the desired outcome for that individual, or it maybe isn't realistic for that individual. It doesn't work separately from abstinence, but it can work hand in hand with an abstinence model, which I will get into more detail about a little bit later. It's also really important to point out that it is part of, I'm going to keep talking about a spectrum of services and a spectrum of care. 4-pillar strategy, which Vancouver has, again I'll talk about in a bit more detail later, is a really important emphasis in harm reduction and with prevention, treatment, and enforcement. And really one of those can't stand on its own, really address this issue effectively. So getting a bit deeper into the principles of harm reduction, you'll see on your screen the 5 core principles around harm reduction. So pragmatism is really recognizing that we're all beings, we're all going to engage in high-risk behaviors, and substance use and addiction is a really complex issue. We live in a society full of individuals, and no one solution is going to work for every individual, and so that's where it's really important to have a full spectrum. And that ties into maximizing options. So when we talk about harm reduction, we talk about that harm reduction is the only solution to things. It's an option. It's available to people, and it's important to provide that option to people. Focusing on the harms a lot, and so there's increasing that safety around the actual activity. And then the active participation and emphasis on human rights is really recognizing the autonomy of people and the right people have to make decisions around their practice. On the phone, if you could meet, that would be fantastic. Thank you. So really focusing on, and the nursing role in it really you're there to provide more decision around engage in and how they live their life.
Phone is cutting out.
Okay. Is that a bit better?
So we can hear music. Someone doesn't have their phone muted.
Make sure their phone's muted.
If you're playing The Hills by The Weekend, you need to mute your phone.
Music. Perfect. Thank you. Okay. So yeah, it's really, as a nurse, you're there, that education, provide that support that you're working with. So why is harm reduction so controversial? Where this comes from is people often frame harm reduction as a contradictory intervention to prevention and treatment of abstinence, and people don't see how together with reduction of harm reduction, and these policies actually and can complement each other in.
Sorry, but the line is really bad. I can't hear what you're saying.
If everyone could please mute their lines, it's causing feedback for people and it's making it hard for everyone to hear. So if you could just mute, we'll take questions at the end, but if you wouldn't mind just muting, it's just really difficult for others to hear.
Just move the microphone a bit closer to me and we'll see if that hopefully helps. So a little bit around some of the myths associated with harm reduction. I'm sure a lot of you have heard these, whether in your career, working as a nurse, or in your personal life, or even in media. And we'll get into some of the but it's to know that, especially a lot of people emphasize that harm reduction is enabling and it promotes substance use. But really, there's really robust evidence throughout the world that actually demonstrates that it does not enable drug use and that it actually promotes people engaging in healthcare and social services, which is a very positive aspect of harm reduction, and it often reduces some of that public disorder that a lot of people fear. If you have a supervised consumption site that everyone's going to be publicly using in the street in front of it, and there's a lot of evidence to show that that's actually false and that is a myth. So just to give a little bit of history, we're very lucky to live in BC, as BC has been a leader in harm reduction, as we've been working with harm reduction programs and principles in our practice for over 25 years. The timeline that you're going to see on your screens is not an exhaustive list of harm reduction programs, and at the end of the slideshow, the resources will be listed and the full comprehensive timeline is available there. These points are really to emphasize some key moments in harm reduction history and where we've come and where we are today. So back in 1989 was the first needle exchange program in BC that was opened. and that was actually opened in the Downtown Eastside Youth Activities Society and the North Health Unit. Now, just to define quickly what a needle exchange program is, and we've moved away from this model now, but throughout the world and North America, there are still some places functioning under the exchange model. And the trouble with that is I am sharing a needle with my partner, and we're using together, and we went to a needle exchange. We would bring our one used needle, and we'd be able to get one clean needle in return. And so it perpetuates that cycle of sharing injecting equipment, and it doesn't actually address the issue of that shared equipment that then leads to transmission of communicable diseases and bloodborne viruses. And so, as you can see on that timeline, in 2002, BC actually shifted from a needle exchange model to a needle distribution model. And so what that means is now I can go to a needle distribution site, and instead of needing to return my used equipment in order to get clean equipment in return, I could go and I can ask for supplies, and I could ask for an unlimited supplies. I could ask for 100 syringes, and I should be able to get those 100 syringes. And so that's really promoting access to clean supplies, and it's been shown to really significantly reduce the spread of bloodborne infections such as HIV and hepatitis C. So going back to our timeline here, in 1997, there was a public health emergency declared in Vancouver, specifically to the downtown east side in particular, and that was related to opiate overdose deaths, rates of HIV, rates of hepatitis A, B, and C, and syphilis. And it was a really localized emergency that was happening, and there was a lot of really grassroots activism from the people with lived experience who were being impacted by it, as well as health professionals who were working in the area and seeing the impact it was having on the community. That public health emergency in 1997 led to a lot of innovative change locally in Vancouver as well as throughout the province. It led to changes in the methadone maintenance program, increasing access to methadone as a replacement therapy for opiate use, as well as many other interventions. 2001 was when the City of Vancouver adopted the 4-pillar drug strategy, and that's what I touched on before, where it's those 4 pillars of treatment, prevention, harm reduction, and enforcement. And it was a really groundbreaking thing when they actually adopted that policy, because it was our local government acknowledging that funding just one of those aspects was not going to adequately address the issue that was at hand and the public health emergency that was happening in our city. And so it really promoted collaboration between those different sectors and looking at them as a continuum in the intervention. And that's really groundbreaking. In 2002, we did that transition to needle distribution, and that was actually also when the Dr. Peter Centre in Vancouver started providing supervised injection. Now, many of you are probably familiar with Insight, which opened a year later, but it opened very differently. So the Dr. Peter Centre came out of nurse advocacy, where nurses were recognizing that there was a need from their clients that they were servicing their program for this service, and they were looking to the regulatory bodies, the ARNBC, which still exists today, and looking at code of ethics and our professional standards and recognizing that it was actually our duty to provide this care and that it was within our scope of practice. And so it was in 2002 that the CRNBC actually recognized that it was within the nursing scope of practice for nurses, for registered nurses to supervise injection and provide that service to promote health and well-being in the client population. So conversely, 2003, Insight opened under a different model. It's a standalone injection site, whereas Dr. Peter Centre is integrated into a spectrum of services. And so Insight opened with an exemption to Section 56 of the Controlled Drugs and Substances Act. So what that means is staff members and participants, when they're physically inside Insight, they cannot be criminally prosecuted for having possession or using substances that are considered illegal to use. And so that created some protection and created a safer space for people to be able to come in and use their substances in a non-judgmental environment. So Insight has had a bumpy road along the way, and so in 2008, the federal government refused to renew Insight's exemption to the Controlled Drugs and Substances Act. This was quickly responded to with a constitutional challenge by the Portland Hotel Society, who co-runs the facility at Insight. And over the years, it worked its way up through the levels of court, eventually to the Supreme Court of Canada. During that time, Insight was able to continue to function, which is really important because it is a vital service to the community. And then in 2011, the Supreme Court of Canada unanimously ruled to uphold Insight's exemption and deemed it a human right for people to access services such as supervised consumption. And then, as some of you may be aware, earlier this year, shortly after the federal government was recently elected, the Dr. Peter Centre actually officially received an exemption to Section 56. They had continued to operate since they opened in 2002, but this just provides a bit more security and support to them continuing to operate. And Insight received a 4-year extension so that we don't need to apply every year to renew that exemption. And then in 2012, the provincial Take Home Naloxone program and the Towards the Heart program were launched by the BC CDC. Since then, they have rapidly expanded, especially recently since the public health emergency was declared in April. And it's a program about taking naloxone, which is a substance which temporarily reverses opiate overdoses, into the hands of people who are using substances so that they can intervene if they aren't able to access a service such as a supervised consumption site. So trying to improve skills, knowledge, and safety in the community for people. So moving into some more specific types of programs that are available within the harm reduction spectrum of services. I've talked a little bit about needle distribution recovery programs, and then to get into some of the research that's come out of it, there's actually really strong evidence that needle distribution programs, not exchange, but actually distributing the supplies, has reduced HIV risk behaviors, and that's that sharing of injecting equipment. It's also been shown to increase access to health and social services for clients who've been deemed difficult to access, or people who normally wouldn't be engaging in those services. There's also no evidence that it increased rates in crime, drug use, or public disorder, and it's been shown to be really cost-effective. If you think about the cost of a syringe, that's a few cents per syringe versus the cost of lifetime HIV treatment for somebody if they contract HIV through sharing of supplies. And so really when you think about that cost benefit, it's a really low-cost intervention in harm reduction. Next, supervised consumption sites. To put this more in context, I'm sure everyone who's on this call right now throughout BC, I feel very lucky to be in Vancouver, where we actually have access to supervised consumption sites, and there's plans for more. Outside of that community, and I mean, we see it in Vancouver, if people don't have access to that service, the places they're choosing to use is in their private home or on the street often. And so if you think about the risks of using substances, if someone's using in their home, okay, they've got a bit of control in the environment. They don't need to risk that. They don't need to fear that criminalization, that they're going to maybe get arrested or criminalized because they're using a substance. And they can maybe control the cleanliness. They can have a clean space so that they reduce their risk of infection. People are using alone often, or maybe they're using with friends, but everybody's using. There's been a few stories in the news lately of, there's been a group of 4 people using together and they all overdose and nobody's able to intervene. So, it's not the safest space to use it. The other option on the street, we've got people using in alleys which are also functioning as people's bathrooms. And an injection is meant to be a sterile procedure. And you're doing this where someone else has urinated or they've defecated. It's a really dirty environment. You've got fear because police might come along and find you trying to use. But in some recent stats that have come out, in terms of overdoses and deaths, a lot of overdoses are being reversed on the street. So it's a bit safer because if you do overdose, someone's probably going to find you and they can intervene, whereas more people are dying using in their private residences. And so really, when you look at those are our two options, this is where harm reduction is really key. So you're taking people out of those two environments where one of them, okay, someone might find you and reverse that overdose, but you're putting yourself at risk for infection that could be life-threatening, HIV, hepatitis C, or you're in an environment in your home where you're at risk no one's going to find you, and you bring them into a hygienic environment where it's controlled, you're in a non-judgmental environment where you're not going to be criminalized for your actions, and you've got trained staff members who can oversee what's happening, and they can provide you with education so that you can actually improve your injection techniques, so that you're going to cause less damage to your veins. If something goes wrong, they're there to intervene. And so that kind of puts in context, where the goal is to bring people out of those environments and into a model that is really more effective at reducing those harms of that substance use. And so Insight alone has had over 30 research articles published that shows that it's reduced the negative consequences of opiate overdoses, it's reduced transmission of communicable diseases, of bloodborne viruses such as HIV and hepatitis C, it's reduced public disorder, and again, increased access to health and social services. When people are able to come into a space such as needle distribution or supervised consumption, those staff that work there become a familiar face, and people can become comfortable opening up and asking for help. Asking for help is a really challenging thing. We're all human. We all think we should be independent and we should be able to take care of ourselves. But creating that space where it's okay to ask for help and it's okay to reach out, and then we can support each other and engage people back into services that they may have disengaged from because of negative experiences previously. A few other strategies, outreach strategies. So this could include peers of substance use. This could include nurses, doctors, nurse practitioners, unregulated health professionals. And it's another really key intervention. A lot of it's around emphasis around education, around distributing supplies to people. From my personal perspective, that, even doing outreach and, bringing a woman who's working in survival sex trade a sandwich and a juice and some supplies, that's harm reduction, because otherwise she might not eat that night because she needs to work in order to make her money, and is she really going to have the time to leave and go feed herself? So, we all enact harm reduction, we just don't always name it, and so, we're talking about substance use, but I really want everyone today to really think about how you are currently enacting harm reduction and looking at, okay, how can you make that more robust, how can you name it, and how can you bring it out more? So outreach strategies, again, have been shown to be really cost-effective. It's been shown to increase access to testing. A lot of people, they do outreach, collect samples for STI testing, HIV testing. It's engaged people in treatment. Again, that engagement in health and social services. A lot of people who use substances are very marginalized. They're pushed to the margins of our society because socially it's not an accepted activity and it's something to be ashamed of. And so that culture in our society has pushed these people away from that engagement. And so this outreach strategy is us going out and making that effort to engage people and bring people back into that circle of care, whatever that circle of care looks like for that person. And in harm reduction and in all healthcare, it's really important. We need to honor the autonomy of that individual. And so it's all about meeting that person where they're at, walking with them in their journey, and accepting them. And it can be challenging. I've had challenges with that in my own work, because sometimes you feel like, okay, that person has a wound right now. I really want to clean that wound and put a good dressing on it, but maybe that person's been kicked out of their shelter and has been sleeping on the street the last 2 nights and haven't had a good meal. that person doesn't really care about that wound right now. They need to get food. And so if we can reach out to people and engage them and ask them what are their priorities for them that day and address them and what their priorities are, then that provides opportunity for them to then come back to us and then allow us to address that health concern. But it is a challenging shift in practice, and as nurses, we have that knowledge in us, and all we want to do is share it. And so it takes a lot of self-reflection to really contain that and really center ourselves around the client. Another strategy, overdose prevention strategies. So the Towards the Heart program and the Take Home Naloxone program that's being run by the BC CDC is a great example of it. And so that program provides training to people on recognizing opiate overdose, how to reduce the risk of overdose, and how to provide emergency first aid, including administering naloxone. And it's been shown to be hugely successful, reversed thousands of overdoses, and just that education is a huge piece. I know personally when I first started working at Insight and I'd come across an overdose on the street, that person, they'd be centrally cyanotic, they'd be pale, maybe not breathing. I don't know how long they've been down for. We provide the best intervention we can. Most of the time we'd have positive outcomes and hand off to EMS. These days, what I'm finding more and more is as I'm approaching that person, I'm able to see that somebody's administering rescue breaths to that person before I've even arrived. And when I arrive, that person's administered the first dose of naloxone. And so this program is just improving outcomes for people, reducing that death and disability that opiate overdose is causing. There's also there's no evidence that it leads the naloxone program leads to increased drug use or risk-taking behavior. And yeah, it just provides vital knowledge, tools, and skills for people to save lives. A few more. So drug replacement therapy and maintenance therapy. The ones that people are probably most common with are methadone and Suboxone. And more recently, an exciting development is diacetylmorphine, or heroin replacement therapy. It has recently been approved by Health Canada to be prescribed by physicians as replacement therapy. Currently, it's only being provided at Crosstown Clinic in Vancouver. And so the goal of these therapies, again, it's not in conflict with the abstinence model, but it's part of that spectrum of services. And so what it is it's meant to take away those initial withdrawal symptoms during detoxification, and then it allows someone to stabilize in their life. And so research shows that if people are on a maintenance stable dose of an opiate replacement therapy for usually at least 3 years, and then they choose to come off of that replacement therapy, in terms of long-term abstinence, there's actually evidence of really positive outcomes as compared to people who go cold turkey, so to say, and just cut themselves off and try to stabilize their health as well as their social life while abstaining from substances. And so, again, it's a harm reduction intervention to provide that substance to someone at no cost to help them stabilize and to achieve whatever goals they have in their personal life. Another one is the Housing First model. And so this model came out of, historically, there's a model of, okay, you have a mental health issue, well, we're not going to treat that until you're abstinent, and we're not going to give you good housing until you're not using substances anymore. And so, people would go through a detox program, and, that usually lasts about a week, and then they would then qualify for housing, but then the wait to get into housing is maybe 6 months, a year, 2 years, and that person is likely unable to maintain that abstinence while living on the street or living in a shelter. And so the Housing First model promotes that individuals who are living with mental health challenges, people who are living with substance use and addiction, that if you provide housing for those individuals and stability in that housing, it then provides the space and the capacity for that individual to then choose to address other challenges that they're facing in their life, such as their substance use. And it's been shown to be hugely successful. The evidence shows that there's a decrease in emergency room visits, police encounters, and alcohol use. Sorry if I'm ranting a lot. I'm getting my time warning. So harm reduction in nursing practice. I've been kind of going on about this throughout it, but really, I mean, if evidence in that timeline even shows, nurses have played a huge role in developing harm reduction strategies and programs, and nurses can really positively or negatively impact patients' experiences. We are often the first contact and the most frequent contact with a lot of clients and a lot of community members, and so we often represent the face of healthcare, and so it's really important from my perspective that we approach clients in a non-judgmental, open way, and really we have the privilege as nurses of walking that person's healthcare journey with them, and it's about being with them and helping guide them, but letting them guide you as well. Harm reduction nursing practice, it's consistent with the CNA Code of Ethics. It aligns with the ARNBC Professional Standards of Practice. And it's becoming, there's the growing body of evidence is just further supporting nurses in this practice and providing low barrier care to community members throughout the world, hopefully. So complexities around substance use. We need to recognize that substance use is a really complex issue. Going to keep going back to everyone's an individual. No one's situation is the same, and no one treatment is going to fit everybody. And so really shifting the focus away from that societal shaming of the use of that substance and focusing more on the individual and looking at their skills and looking at their health behaviors and supporting that person. And if they choose to continue to use that substance, that's okay. What else can we do to support that individual, and how else can we support that individual towards their own goals and positive outcomes? One of the big things that was a huge learning curve for me is it's a success if someone who's been injecting for 20 years, who usually doesn't use an alcohol swab before they inject, if one day every time I see them, I'm providing a gentle reminder when I'm in their booth with them, like, oh, hey, do you mind if I just swab your arm for you, just clean that vein before you go into it? And then one day I see them from across the room using that swab on their own. That's harm reduction. And that's hugely powerful. And we need to challenge ourselves to accept people for who they are and accept people for where they're at and celebrate those small successes. As little as it sounds when somebody uses an alcohol swab, it can actually be hugely powerful. And so just really focusing on that. Our role is just promoting health action, building capacity, empowering individuals, and focusing on that opportunity. And just being there and being present can be hugely powerful. Just to kind of ground this a bit more in some principles around nursing practice before we wrap up. You probably sensed some of these undertones as I've been talking for the last half hour or so, but really building trusting relationships don't happen overnight. It takes patience, it takes endurance, and it takes creating a culturally safe space for your clients and community members to come forward, and seizing those teachable moments and those small successes and supporting those individuals is huge. Not judging people, cultural safety, and empowerment. Yeah, I mean, these are all built into the cores of our nursing practice, but I think one of the big gaps is, as nurses, we need to name what we're doing, and we need to name it, and we need to say what we're doing, and just being self-reflective in our practice as well. I know I don't miss journaling from when I was in nursing school, but it's a really important practice to look back on our interactions, and only by reflecting on our interactions and our practices are we really going to improve our care delivery, and that self-awareness is, huge. Strength-based approach, motivational interviewing is a great skill in harm reduction, and it's really effective in empowering people and building trusting relationships. Is focusing on clients' strengths and their knowledge and their capacity and their skills, and it's about being there to support that individual where they're at. I feel like a broken record, but it really is what it all comes down to. Trauma-informed practice, really important. If some of you are aware of trauma-informed practice, there's some great practice documents available. I know that in Vancouver Coastal Health there are some seminars that are held every so often around trauma-informed practice, and it's a way of delivering care. It's similar to cultural safety, but it's recognizing that often individuals have experienced trauma and recognizing that and working towards not re-triggering that individual. And a lot of the clients we work with who use substances have experienced previous trauma, and some of that trauma has been experienced in the healthcare system, and that trauma has actually been caused by health professionals. And it was never intentional, and I don't want to blame people, but that's the reality, and that's happened. And so what we need to do is we need to rebuild that trust, and we need to acknowledge that that previous trauma has happened, address that, and then ask that person how you can help that person move forward from that trauma, and how you as a health professional can reduce trauma in future engagements. So important for you guys to look into. That could be a whole nother considering the root causes of substance use. Social determinants of health are huge. Poverty, racism, there's so many issues that feed into this criminalization. It's so much more complex than just health. And, that comes back to the 4-pillar model. There is some enforcement, there's treatment, there's prevention, there's harm reduction. And you look at, it's like my example of that person who hadn't slept for a few days and hadn't eaten. I care about their wound care, but they don't care about it because their other social determinants of health aren't getting taken care of. And so looking at that whole person and where that person is so important. And self-reflection, which I could to you about for Dave. So just to close, this is a great quote about harm reduction and nursing practice. I don't want you to save me. I want you to stand by my side while I save myself. Yeah, I think that's everything. Other resources. Katie has great resources. They do webinars sometimes. They've got some pamphlets as well, videos. Yeah, and there's tons of resources at the end of this PowerPoint, which you guys can take a look at later, because all of this will get posted. Thank you. Question?
So we do have quite a few people on the line. If you do have a question, if you can click on your raise your hand icon that's located on the right-hand side of your screen on the navigation bar, it would flag your name, and we can answer a question.
I answered all your questions. That makes me feel good.
And if you want, you can also raise a question through the teleconference line. I know we do have a few harm reduction experts on the line, so feel free to jump in as well.
Hi, it's Raj. I have a question.
Yes.
I'm sorry I was a few minutes late joining the webinar, but thank you so much. And what I might have missed at the beginning is whether this is going to be available for me to go back and view.
Yep, absolutely. We're recording it right now, and it will be archived on our website, so please do come back. We'll get it posted within the next week or so.
Okay, thank you.
Yes, go ahead. We can hear you.
Any other questions on the phone or online?
Hi there.
With the Narcan, naloxone distribution through public health, is that provincial?
Yes. So the BC CDC is running that program, and so they support programs throughout the province. And so if you visit their site, towardstheheart.com, it's got all the resources as well as a info book on how to start a program if you're interested in starting the program in your community, in terms of what resources you'll need, an education packet for training your staff, and then for your staff to train your clients. And it's all at no cost to your program, and they'll send you the kits as well as training supplies, so practice ampules and syringes, so people can practice the administering, breathing masks, all of that.
Any other questions?
I have a question about Housing First. My name's Antoinette. I know that there was a pilot project, and I'm wondering if there's anything left of that in Metro Vancouver.
I'm not sure if the Housing First specifically is happening anymore, but I am aware that there are low-barrier housing programs that are functioning under a similar model to the Housing First specific program, where they're emphasizing people's access to housing, whether they are still using substances or have unmanaged mental health challenges. So there are advocates for that in the community, and there is housing available. But I'm not sure about the Housing First specific program.
Okay, thank you.
No problem.
So I see a hand raised from Antoinette Jonker. It was Antoinette? Okay.
Do you want to pop that out and you can see the whole list?
Lindsay Jones, have we answered your question yet?
No, I just have a question. First off, thank you very much. It was wonderful. With the new regulations of heroin being prescribed through physicians, how do you see this playing out with Insight?
So, great question. Thank you. Unfortunately, prescription heroin doesn't fit into the model of Insight. Insight's intention is people bring substances usually acquired on the illegal market that they've purchased into the site and use those substances. So people aren't using prescribed substances typically inside that site. So under our exemption at Insight, we can't actually prescribe injectable heroin and then have people injected at Insight. But there is hopes that that program is going to be able to expand outside of Crosstown, and really you don't need to be in a model like Insight. The hope is that it'll become something that can be prescribed through addiction specialist, or maybe eventually down the road any GP who has their certification could prescribe it. I know right now it'll be challenging to access, but there is a lot of motivation in the community, I think, to increase access, as Crosstown is bursting at the seams in terms of their capacity of how many people they can have. It is just challenging logistically because it is twice a day prescribed injections, and so some of those logistics need to be figured out before it's expanded.
Thank you.
Jenny Radmacher, have we answered your question yet?
Hi, I think I just clicked the wrong button, actually, but...
Sorry.
We'll forget it. What is the little question mark? Written a question? So do you see there's little questions in that? Yeah.
Right.
Any other questions?
Yeah, Lindsay Jones here again. Just a question. Is there a way you can click back a screen so I can just I would like to read some of your resources.
Yeah.
Thank you.
I think we just went forward a screen. If we go back, there's that, and then I know we've got at least 2 or 3 more screens with more references and resources as well at the very end. And this PowerPoint will be getting posted along with the presentation, so you will be able to access this list of resources once it's online on the ARNBC